I really feel honored to speak. And in addition to stating that I have no financial disclosures, but for the sake of transparency, I must disclose that these are my grandchildren behind me, but they receive no financial benefit or compensation directly for their participation in this grand rounds. I do actually have a disclosure which is personal as well as professional. Zach Cotliar, the little guy on the bed, whose cousin is cuddling him, has BWS. And as you all know, that's a congenital overgrowth syndrome. And these youngsters have increased tumor risk for embryonic tumors. There are some reports, though, of cutaneous malignancies in these kiddos. Although rare, there is, in this syndrome, an overexpression of IGF-2 and or loss of CDKN1C on chromosome 11, P15.5. And I'm sure if I'm wrong, Dr. Martinez will correct me. And the concern was a 13-year-old young man with BWS who developed a spitzoid malignant melanoma, Clark level 5 in Breslow, 4.8 millimeter. A thick lesion is considered more than 1 millimeter. This young had a 4.8 on the right cheek. Not quite sure how long it had been going on. My concern is that we see youngsters all the time, and we try never to say something's rare because that's never comforting to anybody. So certainly I'm concerned about my grandson and monitoring him for all the things that can occur. Finally, all of us have become all too familiar with the positive internet sign. And I make a strong case to the parents and caregivers to use the sites I give them. In doing a review for Dr. Yazdani's text, there was a study done 2007, it was published, it was done in 2006, where a group from UCSF, Columbia, Kansas City Children's, and I believe Yale, just searched the term hemangioma. They got in excess of 1,180,000 hits. They took the first 50 just randomly, which admittedly is not a controlled way to do it, but the amount of loop around back to the same sites and the information, it was amazing how non-productive and non-helpful it was. So I really do make a case for the websites so the parents don't waste time and certainly don't waste money in buying diets or other cockamamie things. It's important that you know these sites, particularly for the entities that you deal with. A good overall site is the Skin Cancer Foundation, which is one that we use a lot of. Got it. Okay. So as I said, I have no conflict of interest in relation to this presentation. This could not be done without the work of these two young colleagues. Candace, who was a senior last year and finished, for her senior elective, she did a resident research month, and she worked on actually it's on Moodle, it's a booklet to show our practitioners, our medical students, what they should be looking for, which ones they need to refer. So I think that really is helpful. It gives you a good sense of what you should be looking for, which things you need to refer. Building on that, Elizabeth Dupuy took that, and we went through a lot of literature, and she really did a tremendous amount of work in preparing this grand rounds. Candace, unfortunately, is attending a funeral of a close friend up in Fresno, and Elizabeth's on call at Cedars. So hopefully Elizabeth thought she could watch it. Candace will get to when she returns. Okay. So basically, we look at case presentations, epidemiology, and risk factors of pediatric melanoma, okay, pigmented lesions and other neoplasms in children, and how do we protect our children. Okay, so you get called to the newborn nursery, and you look at this youngster who was born with this large congenital nevus. On physical exam, you notice a large brown plaque with regular, well-circumscribed borders, 16 centimeters by 8 centimeters. Notice also what we call the satellite lesions. There we go, okay? So these are the satellite lesions, and they'll come into play a little bit later in the talk. This is a healthy 15-year-old who presents to your office for evaluation of moles. She has 50 to 60 small brown papules distributed on the face, arms, and trunk that have recently increased in size and number. They're uniform in appearance, symmetric in shape, and have regular borders. The patient's maternal aunt was recently diagnosed with melanoma. This is a 7-year-old male, comes to clinic with this rapidly evolving flesh-colored mole, which is circumscribed. It's 1 centimeter in diameter, smooth texture. And this could be described as a pink dome-shaped papule. Okay, skin cancer is the most common type of cancer. 1 in 5 Americans will develop it in their lifetime. 5 million people are treated every year in the United States. Rates of skin cancer in adults and children are increasing. And acute and chronic sun exposure seem the major issues involved. Okay. Most skin cancer deaths are due to melanoma, and these numbers reflect that. It reflects the cost. And more than 90% of adult melanoma cases are attributed to damage from UV radiation. Okay. So over 1,300 cases, and this is the meeting that was held in September, and this is the data from that meeting. And you can see that the highest incidence is among girls aged 15 to 19. And the reason for this increase in melanoma seems to be exposure to natural and unnatural UV light. Some studies show increased incidence of melanoma with advanced maternal age and increased reporting or increased diagnosis because of the awareness we now have. Okay, this was from a review, or actually a study that was in Pediatrics 2013, and melanoma is increasing among adolescents. While overall trends were similar for both genders, melanoma incidence in boys is specifically increasing on the skin of the face and the trunk, but only on lower limbs and hips for girls. 0 to 9-year-old melanoma incidence was fairly stable from 1973 through 2009. Okay. Tanning booths have been one of the major reasons, and the UVA exposure that these youngsters get. Many states now have ruled that age 18 is the earliest you go to tanning booths because there are really no controls on visits, and people would join multiple ones and have this sense that they were not doing any damage because it's been advertised as safe, and it certainly is not. We see a lot of atypical moles as a result of that, as well as what we call tanning booth melanoma. Okay, this shows the way that melanomas present, and the length of the line represents, okay, the more common or the higher number that present that way. So in utero, birth, age 1, puberty, and most melanomas in children arise de novo. That's important to make note of. As part of a dermatologic exam, you need to be aware of Fitzpatrick's skin type. Tom Fitzpatrick was the endowed chair of dermatology at Harvard, and he came up with this in 1975, and it's still used in terms of assessing people's potential to burn and how susceptible they are to freckling. If we look at the non-modifiable risk factors, age, pigmentation, nevi pattern, genetics, family history, and comorbid medical conditions, the phenotype which has the highest risk for developing melanoma, is blue eyes, fair skin, red hair, and high density of freckles. Those seem to play the highest role. A Mayo Clinic study that was done in, actually a retrospective study was done 2000 to 2015, and they looked at 86 patients with 99 melanomas, and the majority, 50 of those 86 patients, occurred in Fitzpatrick skin types 1 or 2, which makes sense because those are the most susceptible to sun damage. And the majority of those, or 20% of those, let me correct that, 20% of those, family history of melanoma, and the median age of pediatric melanoma in that study, again, a retrospective study from the Mayo Clinic, was 17 years of age. Okay, so now we talk about modifiable risk factors: sun exposure, sun protective behaviors, the indoor tanning, phototoxic meds, dose-dependent effect of immunosuppression. The gentleman on the left over there is a heart transplant, and this is a squamous cell on his ear. You can see it right there. This gentleman was a renal transplant, and you see both squamous cell in there, okay, squamous cell, and actinics. This is a 32-year-old woman who had a renal transplant at age 16 and developed a squamous cell that was metastatic. And you could see the lesion on the toe, and she had multiple mets in other places. So these are the modifiable risk factors. There are a group of familial skin cancer syndromes, and the melanoma predominant syndromes, which is primarily the hereditary melanoma, familial atypical mole and melanoma syndrome, the BAP1 cancer syndrome, susceptibility to melanoma and renal cell carcinoma, and there's the melanoma including syndromes, as you can see. Non-melanoma skin cancer. Predominantly basal cell is which is the most common, and squamous cell, which is the next most common. It's rare in children. Frequently in children, there's a delay in diagnosis, and predisposing conditions and or iatrogenic risk factors play a role. Subsequent skin cancers and precancerous lesions like actinic keratoses are common. 80% of non-melanoma skin cancers are basal cells. Appear small nodules or papules on the cheek, nose, or eyelid. Childhood and recreational sun exposure play a role. Associated genetic disorders, and there's been cases of idiopathic basal cell. And the one on the top is a 7-year-old youngster whose diagnosis was delayed for about a year, thinking this was a hemangioma, thinking it was a Spitz nevus, and a whole bunch of other things before it was biopsied and shown to be a basal cell. He then had Mohs surgery. The one down here, this is an 11-year-old girl who also spontaneously showed up with a basal cell and had no history that would lead you to think that she'd be more predisposed. Squamous cells are much less common, very uncommon in children, may appear as a nodule or red scaly patch of skin, and it's usually located on the face, ear, or lip. And again, the Fitzpatrick skin types 1 and 2 are more predisposed to that than the other skin types. Okay, so here's a lesion that was around for a while. It was this keratotic horn, okay, which is just a keratinocytic lesion. When it's finally biopsied, it was noticed to have this calcification in it. But when you see something like this, regardless of age, it really is a biopsy diagnosis. People who train at the Mayo Clinic, believe it or not, trained by differential diagnosis. So for a red bump on the arm, they could name 32 things. I could name 5 or 6, probably be in the 5 or 6, but it's impressive that they could name 32. I can't. Okay, so this is a pilomatricoma, which is a benign tumor arising from the matrix cells of hair follicles, and it often calcifies. It can be present in infancy or early childhood. It's solitary, firm, asymptomatic, and it's usually 1 to 3 centimeters in diameter. And it often has a bluish tinge to it. But looking at it, we typically do an ultrasound to see if there's calcification present, and then can plan excision. Malignant degeneration is rare. On Mondays, Noah and I have at least set up what we call the Pediatric Cutaneous Oncology Clinic, or PCOC, to look at youngsters, get baselines of these higher risk youngsters who are transplanted, immunosuppressed, have had radiation, or phototherapy treatment for psoriasis or eczema. So that's important. As part of one of the studies that Dr. Davidson is doing, we're looking at skin lesions. It's part of the protocol where they're using the BRAF inhibitors because of the tendency for these people to develop keratinocytic lesions like keratoacanthomas, which are types of squamous cells. And the one young lady, I think it was a 16-year-old with a glioblastoma, that Dr. Davidson is treating with single therapy. And we've done baseline, 1 follow-up, and I think we have 1 more to do on her. Nevi are common, okay? They are very common. They're a source of concern, anxiety for families. They are phenotypic markers of melanoma risk. They are what prompt specialty consultation. They are heterogeneous, which makes their assessment even more difficult. The most oversold and overperformed procedure is looking at a youngster who has no reason to be in clinic to be looked at for 1 to 2 moles because it's normal. We're not talking about anybody with multiple dysplastic nevi, and we're talking about 50 or more to be of concern. But yeah, parents come in, they want baselines, and it really is a waste of money, time, and it doesn't, you'll see at the end, but screen exams are really overall a waste of time. The natural history. So the first decade of life is the most important time for nevogenesis. Caucasian children develop 15 to 30. African American, Asian, Native American children develop 5 to 10. So the study that was done in Framingham, study of nevi in children, it followed changes of nevi. 75% developed new nevi, and 28% lost nevi over a 3-year period. And this shows you nevi that appear and disappear in the same youngster who was 11 and then followed up at 17. So you can see nevi that have gone, as well as some new ones that have come up. Some of you have seen me walking around with that little handheld thing that looks so intriguing, but really it's just a surface microscope. And in the EU, primarily, there is, to qualify for or at least take dermatology boards, you have to be really competent in diagnosing melanoma using the dermatoscope. It helps. We're not as practiced as they are, but you can diagnose scabies. You can see actually the mite, and you can see the burrow. So it's really helpful. And if you look, this is what things look like with the dermatoscope. And on the upper left, okay, that is a normal nevus. Okay, you can see the globular pattern, they call it cobblestoning. Okay, so that's a congenital nevus. As we come down, this lesion, you can see a little pigmentation here, is a acquired compound nevus. This is a melanoma in situ. And there's some loss of structure, and this is what they call the blue-white or the blue-gray veil, which is somewhat of an ominous sign. In children, most melanomas, have said, or if you take away congenital nevi, but even if you consider them, they are amelanotic, and this is an amelanotic melanoma in a youngster. This is a nodular melanoma in a youngster, and you can see that there's loss of structure, there's some regression, and This is a superficial spreading melanoma, and the big part of this is all the irregularity, the variegation in colors, as well as the regression. The ugly duckling sign is what we call the youngster that has 40 or 30 or more moles, and they all look the same. So you look for the ugly duckling, the one that is different than all the others. All the others are called the signature nevi, and the ugly duckling is the one usually where the money is. Congenital nevi are usually present at birth, the first weeks of life, but the pathologists sort of CYA a little bit, although it's a fact that they could occur in the first 6 to 8 months of life. Those are then called tardive congenital nevi. Okay? So the prevalence is estimated between 0.5% and 31%, differentiated from acquired nevi by distinct morphology and examination with the dermatoscope. Okay? The complications include CNS involvement and melanoma. Okay. So the issue is the categorization. We talk about small up to 1.5, intermediate 1.6 to 19.9, large 20 to 40, very large 40 and above, and then we talk about giant and garment cell. But here's a way to sort of decide what it's going to be, because it's the adult size that we look at. So if there's multiples that you could use, but overall, palm sized on the body is going to be large, and 9 centimeters on the scalp will be large. So they'll be over 20. Neurocutaneous melanocytosis. So this is proliferation of benign or malignant melanocytes within the CNS, often leptomeninges. The incidence of neurocutaneous melanocytosis with giant, okay, so we're talking about 40 or above, is between 3 and 45%. There's a bimetal distribution of onset, symptom onset, which is usually increased intracranial pressure, hydrocephalus, and seizures. And it's usually second to third decades, or 2 to 3 years of age. And they could present with any one of these things. The largest registry is at NYU, and we try to set cases. The risk factors are multiple lesions, and the number that's important is more than 20 satellites, posterior axial location, and large giant size. There are youngsters who just have satellites and have what we know mother lesion, which not common, but does happen. So more than 20 satellites without an apparent larger lesion is still considered for neurocutaneous melanocytosis. Okay, so the risk, and we're talking about lifetime risk, usually always after puberty, or age 17, is about 1%. Risk of melanoma associated with larger giant congenital melanocytic nevi is about 5%. And the contrast, lifetime risk of a mole turning into a melanoma is 1 in 10,000. Interestingly enough, when we look at in the year, if you go back to, I think it was 1970, just let me check the number for you. It was actually, it was 1970. The risk of melanoma was 1 in 1,300, or that's what we saw. Now we're seeing 1 in 30 children born today. So that has dramatically increased. Okay? So factors associated with melanoma risk are giant size, truncal location, the associated satellites, high nevus counts, more than 50, and postpubertal. Okay, when to consider dermatology referral for nevi. So when the adult size is projected to be greater than 20 centimeters, which would be large, small and medium-sized one with significant psychosocial implications located on the face or an area where the youngster might be teased or bullied, on the scalp where it can't be followed. Any nevus congenital acquired with changes that raise concern for melanoma. That means bleeding, rapid growth, change in texture or nodularity, shape or color. Primary care provider requires assistance managing patient parental anxieties. It is apparent and needs to be made apparent to parents that the average youngster may have 10 or 15 nevi without any kind of history of family melanoma in the first degree or second degree blood relative. Does not reduce their own incidence of melanoma forming by removing every nevus that they have. The majority form de novo. That's an important point. And we talk about risk factors for developing nevi. So family history, childhood sun exposure, skin type, and neonatal phototherapy. And there's three types. There's flat, pigmented, which is junctional. Okay? And because the theques or the collections of nevus cells are at the DE junction. There is dermal, which is generally elevated. Okay? This is flat and pigmented. The dermal nevi, the collections or theques of nevomelanocytes are in the dermis, so it's elevated and not pigmented. Compound nevi are both elevated and pigmented because they have these collections of melanocytes both at the DE junction as well as in the dermis, as you can see here. So junctional nevi is just at the junction. Dermal, the collection is just the dermis. And compound, they're in both. Atypical nevi. So benign lesions that share clinical characteristics of malignant lesions. Presence of many atypical nevi does signal increased overall risk for development of melanoma, but they may just be markers and not necessarily turning into melanomas in and of themselves. Okay? They are not, as I said, melanoma precursors. So the standard things we look at are the A for asymmetry, B for the border, C for color, D for diameter, but that's sort of a soft because it has to start some size, and it could be 3 millimeters, it could be 4 millimeters. 6 is 5 or greater, or 6 is what we use. And evolving, which means any change, upward growth, change in an area of loss of pigment, which is regression. So now, this is what we look at in children. This is a whole different set of guidelines. And we talk about the ABCDE cup. So we talk about amelanotic, asymmetry, which is typical in children, bleeding bump, border may be irregular, color uniformity or variegation. So you could see some of these clearly have uniform color. Okay, some have variegation. Okay, this is variegation. They look like pyogenic granulomas, and that's the one thing you don't want to miss. And anytime you take off any tissue, it must be looked at by passing. Okay? Evolving variable diameter. Okay. The color, pink or red. We talk about ulceration along with upward thickening. And this is the important one, the new pop-up lesion, pyogenic granuloma, which is neither pyogenic or granulomatous, but it is a fibrovascular proliferation, often seen post-trauma, but you don't want to miss a melanoma. Sophie Spitz in 1948 called these pseudomelanoma of childhood. You could see what kind of issue that raised because all people saw was melanoma and not the fact that it was pseudo. So that became a major, major issue of contention. So they're now called Spitz nevi, and they're still problematic because there's a whole group of them that are called STUMP, S-T-U-M-P, Spitz tumors of unknown malignant potential. And Dr. Fetterman and I had a young lady who had a wide excision, basically the whole dorsum of the foot for a lesion, then had some lymph node involvement, which you can have pigment in the lymph nodes with the spits, but it wasn't a melanoma. And she came to see Dr. Fetterman, and then along saw me, and she didn't need any chemotherapy, which they had sent her in for, but it had been misdiagnosed. And when we went back at the slide, she did not really need everything that had been done. And they sent her down. She just got into UCLA. She missed a year of school, has had terrible scarring where they did the lymph node resection in the inguinal basin, as well as the graft that covers the top of her foot. And she's really an unbelievable young lady who's really battled hard through this and come out in a great way for her. Okay, so Spitz nevi, pigmented or flesh-colored, typically arise suddenly, located on the extremities, head and neck. They are spindle or epithelial cell, or they have spindle or epithelial cell histology, some with cellular atypia. Okay, 80% will involute, and you consider biopsy when they develop after puberty. They're larger than 8 to 10 millimeters, excessive growth, asymmetry or ulceration. And there's been some cases in the community. I had one where somebody read it as a melanoma, a local pathologist in Orange County, and I had to go back because it wasn't. They wanted to do a wide excision. This was a classic lesion that arose on the cheek of a 4-year-old little girl, and the surgery that they were suggesting would have enucleated her, and it was just so dramatic. I had to send the slide back east to some of the pigment cell pathologists who did read it as a Spitz, and as a group, pediatric dermatologists are much more conservative. When some of the oncologic surgeons see this, they immediately want to do a wide excision. It's not necessary. Many of them involute, and they come up quickly, and if they are outside the things that indicate you need a biopsy, we just follow them. Blue nevi, that occurs because it's a dermal melanocytosis. These have been called Mongolian spots. It's a Tyndall effect that you get this bluish look. There's congenital as well as some acquired. Again, we follow them unless they really look atypical. We tell parents that it does take the Mongolian spots sometimes 7, 8, 9 years to resolve. It's not as quick as we have led some parents to believe. Nevus sebaceous. Nevus sebaceous is a hamartoma of sebaceous glands. And back in the day, they had read 509 basal cells in youngsters, and when all was said and done, they went back and there were 509 trichoblastomas, which are benign proliferations of the hair follicle. And I've seen one that I got a call probably around 1999 on a Labor Day weekend about this youngster that developed a black nodule in the nevus sebaceous, and he came down on that weekend and removed it. They were reading it then as a pigmented basal cell carcinoma, which you can see, but I believe it was a pigmented trichoblastoma, which has also been reported, but a benign lesion. Okay. Historically, we've recommended removal. Any change in these is as adults. Several recent studies suggest that the incidence is less than 1%. It's always as an adult. Now, many pediatric dermatologists, myself included, recommend excision only if the lesion is bothersome, or it's an area where the youngster is typically really bothered by it. You could see it on the scalp. You could see one on the face right there. And this is nevus sebaceous of Yavison. The gentleman who named it is just one of the epidermal nevi. Halo nevi are anti-melanoma antibodies, and as long as the central portion is disappearing in a normal way, and it does not look atypical, you could just follow them. Some people think they repigment. I don't really think they do. If they do, it's much, much later. When they have several, you're concerned. You have to look at family history. also been associated with vitiligo. Myerson's phenomenon is something that you could see over any congenital, pigmented, or vascular lesion, just a little bit of an eczema. It's just a pearl, it's a question, you'll never get asked it. It responds to topical steroids. Some people believe you see it more in atopics. You see it so rarely, but look at when you see some of these youngsters who, where the angel kiss resolves, the stalk bites don't, and they'll often get a little eczema over it. It looks like seborrheic dermatitis. It may be pruritic. You could treat it with topical steroids. So Candace's work was based on a concept that we thought of and spoke about. And this was a study that she did, specialty referral from May 2015 to April 2016 to determine reasons for referral and identify common diagnoses. There was a total of 120 visits, both between clinic here as well as Santa Monica. And the reasons for referral: mole checks, greatly exaggerated, not necessary; unidentifiable lesions with concerning features; evaluation in high-risk patients; and other, which is usually cosmetic. And we often get, well, the father doesn't like it or the mother doesn't like it. That's not reason for removing something, particularly when you see some youngsters who would require general anesthesia. And you try to express the fact that something benign that has no malignant potential, why would you risk pediatric general anesthesia? And the response you get, it's very safe. It is. It's not as safe as not having it. And the other part of the argument, well, the mother doesn't like it, the father doesn't like it. And, none of us are perfect, and we have to accept some imperfections in our kids. So historically, these are some of the reasons for referral: underlying disorder predisposing to malignancy, history of radiation, a past malignancy in the youngster, or transplant, those are legitimate; multiple nevi and family history of skin cancer, only melanoma, not basal cell, unless there's someone with the basal cell nevus or Gorlin syndrome. Okay? Other was desired cosmetic removal. Clinical presentation of the consults: small, medium, congenital melanocytic nevus in a child greater than 10 years old; larger giant, changing congenital nevus; any mole with concerning features; diagnosis of Spitz nevus, nevus sebaceous, or an unidentifiable lesion. Okay, so you can see the numbers. And look at the amount of appropriate referrals as opposed to the inappropriate, okay, and inappropriate referral, but with additional complaint. And that's typically that I was getting irritated, or it will get irritated, or it might get irritated, or I think it was irritated. This is a youngster that I saw recently, and the reason I point this out, this 11-year-old girl with a history of retinoblastoma. The pigmented lesion, as you can see in the lower extremity, was removed by biopsy 18 months ago when I had seen it. And the interval asymptomatic return of pigment that appears atypical. This has a pseudomelanoma appearance. It is benign. It is crucial that you try and have the same pathologist read it and you include the history. Because if they're off at school somewhere and they had this done when they were 8, and now somebody, lo and behold, has noted something, now that they're 22, and I probably see it once every couple of years, and fortunately, we're able to speak to the people and compare the biopsy and not have to worry about it. Because some people want to just remove it immediately with an excisional biopsy, and you really don't have to do anything for it. It's just return of pigment, particularly if you shave something and you leave some deep pigment. It's not an issue, but you need to be aware of the entity because it does really look atypical. If you look at it, you could see the regression, you could see a little bit of difference in color. Regression there, a little bit, I'm not even sure what color that is. Okay, so this is the case one, we're coming back to this. In the newborn nursery, you're called to assess this youngster. A physical exam, you know, large, as mentioned, Okay. So this is a giant, based on size, congenital melanocytic nevus, regular monitoring and routine surveillance for malignancy, referral cosmetic treatment or removal, and you can not do all that much because you're looking at so much skin involved. So what we sometimes do is serial excision of the areas that are visible. And you could do that. Justine Lee has done a number of those for me and has gotten great results. Okay? But given posterior location and the giant size, you have to be concerned about neurocutaneous melanocytosis and or spinal dystrophism. So this is the 15-year-old that presents to your office for evaluation of moles, 50 to 60 small brown papules distributed as you see. They're uniform in appearance, symmetric in shape, and have regular borders. And the patient's aunt was recently diagnosed. Okay? So these are just all acquired nevi. Her moles have all similar characteristics. They're all signature, what we call signature mole, her signature nevus, and should be reserved for lesions that are atypical or the ugly duckling type. Sun protection is the most important thing that she can do because of the number of nevi, she seems to be more susceptible. This is a Spitz in a 7-year-old who rapidly evolving flesh-colored mole above his lip. It's well circumscribed, less than a centimeter diameter, and smooth. So it's a dome-shaped pink papule, and low-risk lesions follow. We follow them every 3 to 6 months, and the indications for biopsy would be more growth, so it's greater than 8 to 10 millimeters, asymmetric, ulcerated, and in children older than 10 years old. Here comes the fun. Okay. As you see, Brazil is the first country to ban tanning salons. If you go into the stores, you will see everything under the sun in terms, and no pun intended, in terms of sunscreens. The new FDA monograph, and they started writing this in 1988. You have to leave it open till everybody who wants to opine does. That includes people with tinfoil hats sitting on mountaintops. Okay. You have to not finalize it until everybody opines. Then you face the companies which tell you the cost to change their labeling. The new sunscreen regulations are SPF 50 plus is the highest, broad spectrum, or UVA and UVB protective, because the system of evaluating UVA, the people who developed it couldn't explain it, the doctors couldn't understand it, including myself, and certainly patients couldn't. So now we just say UVA, UVB, broad spectrum. Water resistant is 40 minutes, very water resistant is 80 minutes. Okay. So obviously UVA and UVB. UVA penetrates glass, okay. And UV exposure increases by 4% for every 1,000 feet, elevation above sea level. Okay, so it's over the counter, regulated by the FDA, and they started working on it in 2000, as I said, 1988. 2011 is when it's published, and it's open still for revisions. Broad spectrum, maximum SPF, as I said, and application direction. Every time we've done studies, people use a teaspoon and a half of sunscreen. The average adult needs 2 tablespoons or a shot glass to be appropriate. Try getting sunscreen on the little ones. It is unbelievably hard. They're pulling away as you're trying to get it on, and it sometimes is really hard. They need rash guards. They need sunglasses. And there is a product, which I have no financial interest in, called SunGuard, which actually gives everything you wash with it an SPF of 30 for 20 washes without damaging the fabric or changing anything chemically that could be harmful. Okay. So the SPF reflects the ratio of radiation received before burning protected skin versus unprotected skin. marginally increased above 30. Really at 30, you get about 96.6 or 7. At 120, and I've seen samples of 110 and 120, it's like grease that you take off the axle of your car, and it probably goes to maybe 97.1. The testing based on application of 2 milligrams per square centimeter, whereas most people only apply, as you see, as I said, a lot less. Okay? The FDA recently added the 4-star UVA protection rating system. Nobody understands. Okay. One of the issues that you face in pediatric dermatology, you face in all medicine, as I said, the positive internet sign, and everybody could see skin, so everybody thinks they're therefore experts to comment on it, right? So the grandmother, the uncle, the neighbor would not even begin to talk to you about your headaches or anything. They might, but generally won't have issues about skin, and they know something that works, whether it's tea tree oil or all the other cockamamie stuff. So the stuff that's arisen on the net, and we're looking at the myths and facts, okay? Sunscreen is not recommended for children under 6 months, okay? So you should consult your pediatrician. Avoid sun exposure. When adequate clothing and shade are not available, parents can apply a minimal amount of sunscreen with 15 SPF to small areas. Okay? A base tan. This is one of the biggest hoaxes perpetrated on the American public. By tanning booths, a base tan will protect me from sunburn. Where tan, back in the day, was something that people liked. It looked good. You felt better when you had one. You didn't have seasonal affective disorder. Actually, a base tan, or any tan, is evidence of skin damage. Okay? So that's equivalent SPF of 4, and tans are indicative of skin damage. Brazil and Australia have banned the indoor tanning. Germany, France, and UK have banned indoor tanning among people under 18. And the proposed regulations here in some states have passed it, under 18. Vitamin D deficiency. Okay? There is studies that show attenuation of vitamin D synthesis with use of sunscreen. No random controlled trials or longitudinal studies have been done that significantly show suppression. And patients with xeroderma pigmentosa who are maximally sun protected because they can't even use regular fluorescent lighting have vitamin D levels in the low normal range, but we supplement them. Oral vitamin D is a safe option when the deficiency is concerned. Okay, the co-administration of sunscreen and insect repellents is recommended. So DEET may decrease the SPF by about 1/3. Insect repellents may change the degree of transdermal absorption, and the CDCMP recommends reapplication of sunscreen and repellents independently. We are not supposed to use botanicals in youngsters less than 3 years old, and DEET is contraindicated in children less than 2 months old. UV filters have hormonal effects. Okay? Oxybenzone and chemical UV filters have been used safely for many years. One publicized study showed that rats fed megadoses of oxybenzone had enlarged uteruses. Studies in the US and Denmark have detected oxybenzone in urine samples, however, levels did not correlate with use of sunscreen. Okay? AAP recommends avoiding it if possible, but acknowledges more research is needed. Look at the amount, okay, years of daily sunscreen application required by an average US woman to reach systemic levels of oxybenzone per unit of body mass equivalent to those given to immature rats. Okay, that's quite a lot. Okay, 34.6 years, 69.3, 277. Nanoparticles in sunscreens are dangerous. They do not infiltrate normal or even compromised skin, which is important. Adult and pediatric skin, usually at 6 to 8 weeks for preemies and some other conditions, but at 6 to 8 weeks, the thickness and the absorption is the same. Okay? Natural protective mechanisms include shedding of the stratum corneum, outwardly directed hair follicles, sebum, And all the studies use tremendous amounts of product and overestimate the potential hazards. This is the latest guidelines, as you can see. The evidence is insufficient, and we have known this, and it's very hard to do because when people come in, they say, oh, by the way, I had this rash, and it's not very effective, and teaching them about sunscreen and how to use it and the protective ways to avoid sun is significantly more important than skin cancer screenings. I do it for Major League Baseball because they use it as a promo, okay? But I do it all during the year. They usually have Melanoma Day in June or July, and they have photographers and things. I avoid it. In my entire career, I was at a football game, and there was a young guy sitting in front of me in a tank top, and he had a melanoma. And when my kids took a break, they get some, I'm sure, some chazarai. I bent over and I said, I really need to let you know that you need to get that checked. And he wanted my name. I said, no, because he was going to come to me, and I find that self-serving. I don't know. I hope he did. But it was clearly a melanoma. He thanked me, continued drinking his beer, and I hope he did. But I find it very difficult because every time, I will never do it in a community. If I do it sometimes for a charity or something, I'll always do it somewhere where I don't practice because I think it's terrible when they say, I don't have a dermatologist. I say, oh, here's my card. So I really have issues with that, and that's why, truthfully, I once did one for Hunt Foods as a favor to somebody, and Orville Redenbacher was there. Orville Redenbacher was a walking squamous cell carcinoma. Red hair, things. His third trophy wife with him did not want me to say anything because he came over specifically because he had sold his popcorn to Hunt's Food. And he came over and said, do I have sun damage? I said, do you have sun damage? And with that, the wife schlepped him away and told me he has his dermatologist. And I couldn't believe the amount of actinic damage and squamous cells that he had. But, you know, no good deed goes unpunished, so I didn't even get any popcorn. Okay, so in summation, skin cancer imparts great healthcare costs, morbidity, and mortality to society. Pediatric melanoma, although rare, and again, nobody's ever comforted by the fact that what they have or their child has is rare, is increasing, clearly. Risk factors include sun exposure, immunosuppression, transplant, radiation, and skin type. Congenital acquired nevi are common. Specialty evaluation should be determined by patient age, lesion size, risk factors, A, B, C, D, E, and the cup criteria. If the pediatricians, it is a pediatrician's role to counsel our patients on sun exposure to reduce the risk of skin cancer development. Thank you.